Shared decision making makes up clinical practice guidelines around the world for pretty much every condition going. Yet, how often attention is given to this area, how confident clinicians are at doing it, and how often it's actually done is up for debate. But we do know that when it's done right, it can help patients feel more involved in their own care and often lead to better outcomes. And so, on this episode of Clinical Communication, I'm joined by David Alderson, who is a senior lecturer at Sheffield Hallam University and also an advanced practice first contact physiotherapist. And on this episode, we're discussing his specialist interest, which is shared decision making, particularly in primary care. On this episode, we're discussing how framing of statistics, choice, and bias can all influence shared decision making and how we can try and control them. We'll also be discussing how to manage expectations during shared decision making and what to do if the person in front of you doesn't want to be involved in the decision making at all. If you find this useful, then please do go subscribe. Please do go and share it with other people. You can find David on LinkedIn. I'm at BYBrowPhysio across social media. David also has a one-day course on shared decision making, which I'll put in the description below. You'll hear us discuss it at the end. Thank you, as always, for watching or listening, and I'll speak to you soon. I find the choice stuff really interesting. I think it was about, I say, a year or two ago that, as you're learning all about behavior change and stuff, and when people are trying to make decisions, and it kind of goes against how we kind of live lives at time because we're having this conversation earlier today at work. You can go into the cereal aisle at work, at Tesco's or any supermarket, and there won't just be like one or two. There'll be, I don't know, 30, 40 plus. And we know from various science that it's too much choice can be overwhelming and then people can't make the decision. My understanding is that the magic number of choices should be around three-ish, two or three. What's your thoughts?
I think that paradox of choice is very real, isn't it? And my favorite analogy for that is Netflix, because I've spent probably in the first period of getting Netflix, you're just cycling through, and then you realize, oh, we should probably go to bed, because we've just watched, the first 10 seconds of this,
Yeah.
and it doesn't really help you to narrow it down. I think certainly with my contact with GPs and
Mm,
listening to them, use these techniques day in and day out, and me thinking, oh, crikey, this isn't how we do it as physiotherapists. It's a lot more staccato, how we gather the information, the conversations that we have don't really feel like conversations.
mm,
Um, and I think the ones who do it very well will present two, and the
mm.
third one's a bit of a backup, and I
Ah.
think for that time where you sort of share those good ones, what you think are the best, knowing as the expert what you know
Yeah.
about the evidence base, what you know about the history, what you know about the presentation, and so on. And then that third one is one, or you could even,
Mm,
what are your thoughts on these? So they can, again, some of that is around listening to what they've proposed as being their concerns, their ideas, and hopefully trying to create some sort of connection between those and those choices.
I never thought of that. It's like you present two and have the kind of third as the backup, so to speak.
Hmm.
Uh, should People often say for shared decision making that we should be in this kind of the fancy word is equipoise, right? We're not biased in any way. We'll come on to bias in a bit. Um, but if you're presenting two, should these, you said they're the two that you think are most likely going to be beneficial. Is that right? And then the third's kind of I would say wild card, so to speak, like a bit more risky.
Well, not necessarily wild card, but with any problem in presentation, the patient would love to believe that there's an infinite list of options. The options that you have for any one condition.
Yeah.
It's not the B and F. It's not like page one, and thousands upon thousands of choices. You're going to have 10 as a maximum pretty much in any given situation. The top three are generally going to be pretty palatable for most people. However, there are some times when a third option, not necessarily a wild card, but an injection would be something that might come into option three or four quite commonly, sort of not the one that you would recommend, not the one that would be the mum test in terms of what you would do. So your mum comes with this problem. She certainly wouldn't have that. But sometimes that conversation, the person's resistant to those. But an injection, knowing the limitations of it, and providing the person understands those limitations and what it might mean for the long term and so on and so forth, it's not an unreal again wild card. I wouldn't call it that, but I would just say that it's the one that you wouldn't put the most weight behind. It wouldn't be number one for the very reason that there are better options available.
Okay. Can I ask about the mum test? I've never heard of this before.
Yeah, so
What's
the mum test is predominantly I don't know. I don't think I've made it up, but particularly at a clinical standard,
right?
is would you want your mum sat in that consultation on the receiving end of that? And I can think of a number of instances where friends and family have reported a case
Yeah.
of a consultation, and you think, oh, God, like that's my mum on the receiving end of that, and you wouldn't want that for everybody because it was
Mm.
just done in such a way. My dad, he's no longer with us, but he had an oncologist who concluded his consultation, concluding his notes with our back to him.
Oh.
And so, was there anything else? No, I let the and just left. And this triggered lots of conversations between me and my parents. There's really some feedback on this. It's not like the 50s and the 60s where you
No.
can't speak to doctors, you can't make complaints because they'll hold it against you. Most healthcare professionals these days will take it on the chin and accept it for what it is. It's feedback, but unfortunately it has to come through a very formal and
Mm.
stuffy PALS type channel that takes 64 days or something like that. So yeah, the mum test is would you want a friend or your family sat with them? And if they wouldn't, there's something about the not just the clinical choices, but the way that that interaction played out.
Okay. Okay. I've never heard of it. I like that though. Yeah. Would you like
Hmm.
it? Do you think it's a bit? I think of the shared decision making a bit like people say about biopsychosocial. Like biopsychosocial approach is something lots of people claim to do. Um, how much they're actually doing it is a bit more variable. Do you think it's the same thing with shared decision making here, where a lot of people feel that they're doing it, or give the impression that they are, but when reality hits, it's not quite as shared as we'd hope.
Yeah, potentially. And I suppose we all have our intrinsic biases. We all have our leans towards certain things. Um, I guess the problem with something like the biopsychosocial model is that term,
Mm.
when you think of all of and something like rapport building and the consultation and understanding individual, that's just one tiny, atom of a huger construct, isn't it? In an ideal world, the biopsychosocial model would be something that you place on the desk and you say, I'm going to use the biopsychosocial model now. But
Yeah,
actually, the intricacy with which that is applied is so
yeah,
difficult.
yeah,
Shared decision making would be one small facet of that.
yeah,
I think using things like hopes, thoughts, and fears, ideas, concerns, and that again, that's another piece of it.
yeah,
Understanding some of the previous experiences of the individual. These are all feeding some of that psychosocial type angle. But to do all of that in one go is it's going some. It's really difficult.
it is. It is. You were saying about the ICE questions. I think and that can kind of guide, in my experience, where this kind of the conversation will go. Because if their expectations are for, I don't know, medication, that may need to come up as one of the options. Because they're probably going to go, if you give three options that aren't medication, they're probably going to go, oh, what about medication? That wanted.
Completely. So that you've inadvertently created a fourth option,
Yeah.
which you didn't really want to do because it's
No.
not top of the pops. We're not kind
No.
of running down from 1 to 10 because then it isn't shared decision making. It's, well, you're the expert, right? So tell me what to do. Um, so yeah, but and I think that is so very important that lots of that information, particularly dependent on how you start the consultation and when you're discussing what's been going on with the patient, the impact of it, and so on and so forth. The vast majority, I would say as many as about three quarters, 75 or 80%, they will all give you something that is linked to ideas, concerns, and expectations.
Yeah.
I don't know how you feel about how frequently that would happen.
Oh, whether it's obvious or whether it's subtle will vary. But agree that there will be, it may even be in the information you've got beforehand.
Hmm.
You might not be the first person seen with this problem. They may have seen 5, 10 people before, and it might be obvious from what they've told other people. But especially if you've not met them before, or don't know, I'd like to think that, as you say, 90 odd percent of the time, before you've even asked the question, there may be some form of sign.
Yeah.
You might be wrong, of course. We're not, no one's perfect at reading people. And sometimes I do get surprises when you think you're going down one lane that looks, and it seems to be going that way, and then there's a sudden turn, and this was not what they were wanting or expecting at all. But I agree. Most of the time, there's that line, isn't it? Like I forget exactly how it goes, but the patient is telling you the answer or the problem to their solution, isn't it?
Yeah. Yeah, that's something that I haven't said for a while, actually, as someone who's not involved with students as much as I would like these days, the odd postgraduate. But the patient is trying to tell you the answer, and it always used to rankle, and I don't see it very much these days in primary care. But when you'd see on medical notes in hospitals, poor historian, which actually that's on us, isn't it? The history is collected and gathered by us, and there might be certain instances where people's cognition in acute settings and so on is changing, fluctuating that would account for the story that they might tell. But you can document that. You don't need to say that because it's really sweeping and generalist. Um, so I think that some of the cues that will come across, like you say, very overt. They'll say the same thing, something about a scan, or they'll say, "Oh, I had a friend who had and a scan's the sort of low-hanging fruit, the one that we'll probably see the most of,"
Mm,
and they'll mention that phrase a few times. So again, if that doesn't make it into that shared decision making,
mm,
all that time and energy that you've spent creating that rapport
mm.
is massively undermined when you go, "So these are your two best options," and they go. And they sit back and they give you very clear non-verbal cues that these options aren't landing,
Yeah,
that
yeah,
they're not happy with those.
yeah.
And they'll say, well, what about? So, like I say, you inadvertently create an option that is suboptimal anyway.
Mm.
So you're best to have that at front and center and say, so there are a few options. And you've mentioned the scan. I'm curious as to
Yes.
what it is you're hoping to achieve with that.
Yeah,
Because
yeah,
there might be times when we have to go down that road
yeah.
because it's so clear and powerful, the history and so on and so forth. And that's okay. As a clinician,
Mm.
sometimes you have to just make peace with that, I suppose.
Yeah. But
Yeah.
you have to address the elephant in the room if there is one. Whether it's scan, whatever the thing is, let's say, if they brought it up so many times or it's clear in they may overtly say it. If it's not appropriate, you could have the best, most appropriate evidence-based options available to them,
Yeah.
but that's all worthless if they're still focused on the thing that isn't appropriate at the moment,
Yeah.
and whether it's
Yeah.
scan, whether it's some procedure, some surgery, something else, or referral elsewhere, that it has to be addressed first, because otherwise you're going to give them the options. They might pick one, but they're still going to go walk out thinking, well, what about the thing that,
Absolutely. Yeah. And that's really challenging on a number of levels, isn't it?
yeah,
So from a personal relationship perspective,
mm,
the so I quite naively, I left a secondary care job to work in FCP, thinking or wanting not to see the same people over and over again. I was a bit
wow,
tired of the rehab and I was a bit tired of the same people coming around. But guess what? When you're in primary care for long enough, that's very much happening.
does it?
Yeah,
Ah,
absolutely. Because in a PCN, depending on the size, people will come 2 years later and you'll search for yourself and you'll say, "Oh, hi, I'm David. We haven't. Oh, yeah, yeah. I remember. Did I come with my knee or my shoulder or some other problem?" So they'll remember. Um, so you are building that relationship for the long term. See, well,
yeah.
you don't want that person to go away and go, "I don't want to see the MSK specialist again because I'm going to go and speak to someone proper. I'm going to speak to the doctor."
Mm,
Because the doctors, the medics alongside us, don't ruminate and kind of inwardly look introspectively so much at themselves by meeting the demands.
mm,
They want something. So sometimes they'll do it as a bit of um, almost like a PR exercise because they know that in 3 years' time, this person's coming back with another problem and they need to maintain that relationship. I think for us as physiotherapists, we've ruminated very much into the evidence base around the negative impact of scans and so on
yeah,
and so forth. And we should, and we should. And I think there's
yeah,
very much a happy medium between
mm,
giving people what they want and grinding the National Health Service to a halt,
yeah,
and also being the gatekeeper that says, well, I can't do it, so I'm not going to do it.
yeah.
There's a middle ground that we can find.
It's been very interesting because I now work in secondary care, and but worked in the classic kind of primary slash initial referral physio before. And yes, we all have the you don't need the scan, it'll be okay, we can do X, Y, Z. And then went into secondary care over 5 years ago and working with medical colleagues, and it's like patients like, I need a scan. Yep, here you go. Oh, well, you know, but it might not be. No, they can just have it. It's all right. And it's, oh, right. Now, it doesn't always happen. It wasn't always indicated. Um, but it's just, I guess, different. professions, and I'm sure it's different for other people who can order imaging as well, whether it's medications or procedures, whatever it is, your threshold, and you said about ruminating there, kind of tolerance with that, all the thoughts and feelings and emotions that come with it will be variable, right? And all your experience as well. Um, it's been interesting seeing the two sides, and I'm sure if you went to GP or a different service, it'll be even more different. And that's just for scans. Obviously, it'll be different for other things as well in healthcare. That and it's always going to be tough when you've got someone who wants something and you want to have the shared decision making conversation, but the thing they want isn't appropriate,
Yeah.
right? Or
Uh,
yeah,
but I would go back to the statement that you made before about the elephant in the room. You
yeah,
know, it's I think I need X. And so exploring some of their feelings
mm,
and beliefs around why that might be, whether that is injection,
yeah,
whether it is some, much more left field ozone therapy or something like that, that you think, well, that is available somewhere,
mm,
but there's a bit of Googling and digging to find out where we might send you for such a treatment and whether that's actually efficacious or not.
yeah,
Yeah, so it's absolutely important that if we don't do that, the person from a not just from a relationship perspective, which I guess is what we touched on before, but also from a system efficiency perspective, they're going to come back. So now
mm,
that single appointment, signpost or triage or however you want to call it, now becomes a second or a third, and no system can sustain that.
no, no. We were talking about uh, choice and options, and we said, there should be a small amount, but sometimes there can be a lot of choice. And I'm thinking more choice for a specific thing, especially exercise, for example. We know for a lot of long-term conditions, very, very rarely is there a specific exercise these days. A lot of the times it doesn't really matter as long as it's something.
Sure.
We could say the same for medications, for pain relief. You could say it for various other things. So you've got this kind of option, but then becomes multiple options. And then again, you don't want someone to get overloaded. So my theory has always been that you start off with a small amount, but then it could be the kind of classic medication exercise or whatever your third is. And then they might pick one, whatever you decide between you, have the discussion, and then from there you then break it down to then, well, which kind of it, and you can then go group or individual, or and you prefer something on the floor or standing, and then breaking it down that way to get to a more specific plan at the end. Is that right? If you've got like tons of options beneath the options?
Particularly from a rehab setting, yeah, you then, in a primary care setting, you're essentially wanting the person to consider if exercise is an option,
Mm,
is it something that they feel that they can take on because they're already active to a point? It would not be uncommon that some people are saying, well, I'm in the gym anyway, what can I do there? And when the flip side of exercise direction is going to be rehabilitation as a really good, and I tend to term it rehabilitation rather than physio. I sort of rail
yeah,
against
yeah,
calling it physio for a variety of reasons, but um, the kicker with that is that, well, you're going to wait. I don't know how the wait time is around you, Ben, but it's
yeah.
4 or 5 months for kind of routine
Oh, really?
physiotherapy where we are. So it's not quite caught up yet. So then that becomes a factor.
Mm,
So I think in a secondary care setting, yeah, you're really thinking about, well, what things do you have to do with your job, right?
mm,
And there's going to be some degree of functional assessment there and then. So then I suppose again, I would avoid going beyond two or three. So there's this sort of that you might incorporate into your gym, or you mentioned you've got some home things. Which of these could you see yourself getting stuck into most easily? Because that's the challenge, isn't it? How do I interweave this
yeah.
into my 168 hours of the week? Where does it fit with work, family, hobbies, all of that stuff that makes us, Mark 1 humans?
Absolutely. And then you and I, and potentially other people listening to this, will be biased. Well, I know from a shared decision making perspective, it should be, equiposed. People have their choice, and we shouldn't be pushing. But we are, even if we don't intend to be, we are going to be subconsciously biased for a certain way. If I'm going to make an assumption, but an orthopedic surgeon's having a conversation with someone with knee OA, they might have a bias one direction. We might have a
Yeah.
bias a different direction. Um, Someone who does lots of prescribing may have advice in another direction. Is it possible, do you think, to control your own biases as completely? My gut's telling me no, even if I want to present it as rational and as unbiased as possible, you're still, even subconsciously, you're going to have, even if you just present it, whatever your thing is first may bias them, right? Do you think it's possible to not be biased in shared decision making?
Yeah, I mean, bias is a fascinating sort of construct in healthcare anyway, isn't it? So,
Mm,
I suppose one thing here is in GP land, they call this beware. They say beware the disease to please. So the a commission bias, so the act of doing something rather than nothing when the choice between is really potentially equivocal. So that's one thing that I think is really key for us, I think. And I remember very much in secondary care, lots of times when it was probably not necessarily clear overtly, but clear covertly, or there were signs, soft signs that people were saying that this is just not for me, rehab right now. I've just got so much stuff happening. I've come because the GP told me to, but maybe it's not quite so overt, it's not quite so out there and on the table. And I've sort of persisted with, well, here you go, this is the kind of thing that might be useful. And then what did they do? Well, they DNA, they don't come.
mm,
And you enjoy getting the kettle on or having a chin wag about
mm.
X Factor on the weekend or
Yeah,
whatever. And there's some reflection about that. So there's that, and I think as time passes, you may have experienced this yourself. You sort of become a little bit more comfortable with saying, "How do you feel about this?" And they say,
yeah,
it's just not right for me right now," and that's okay. Let's save the DNA. However, I think it is reasonable to expect that as rehabilitation specialist, movement specialist, physiotherapist, I would say my lean is towards doing something
yeah.
active to try and rehabilitate the problem
Mm,
than do nothing. The evidence around bias, though, is often from a wide variety of settings. So I've looked at collections of that, and we know that, for example, there's big biases in how we deal with people who don't look and sound like us, people who are different ethnicities, people
yeah,
who are different genders
yeah.
will behave differently around those. But interestingly, in that evidence base, it's a little bit like that the training that they do in recruitment. So they put them through some of the training because it seems to ameliorate the impact of that bias by a small amount. So just identifying that you've probably got some biases, even if you
Mm,
can't quite hit the nail on the head as to exactly what they are,
yeah.
you'll have them.
Mm,
Is that seems to make people recruit in different ways, and I think I suppose that's something that I'm mindful of that I don't. I try to deliberately sometimes not present it as the first option and go, well, you could do nothing here. This is a perfectly reasonable option based on this presentation.
yeah.
There are other things which I can talk about. Or did you have any questions about just keeping an eye on this? And so it becomes more of a shared decision making conversation rather than just you've got this, you've this, you've got this, and you need to choose right now. It's like a Windows salesman. You've got to
Yeah.
choose right now. So it becomes a little bit more organic in terms of how that conversation grows.
I think that's probably a good reason why doing nothing is often said first, because from whether it's my own or hearing, when there's multiple, not multiple, but a few options on the table, usually someone will start with the first thing you can do is do nothing. Do you think that kind of eliminates that? Because we can bias in the order we select it, right? Or we can unintentionally influence. Um, Sometimes people often remember the first thing they hear and then
Sure.
forget the rest. So if we say doing nothing, does that kind of eliminate that, or does that does that make them more likely to then do nothing, uh, which isn't
Yeah.
fine itself?
I think that's a really fair point, and often how we deliver that information, the evidence around if I propose a treatment that I'm really effusive about, oh, shockwave apparently is the greatest thing. It's really great for this problem, even when people have had it for such a long time. The likelihood of a positive outcome goes up, doesn't it? As opposed
Yeah,
to the
yeah,
consultant who, well, I mean, it works maybe one in it feeds into that placebo and nocebo type
mm,
system that we have a belief. So how we deliver it, I think, is important. But also part of me wonders whether starting with nothing is
mm,
is perhaps not, it is quite distant from what the patient is perhaps expecting to hear. So whether this is an intrinsic bias that I'm sort of outing on this podcast, I don't know. But um, I think I tend to use it second. There are some
mm,
things you can do.
yeah,
But one good option is that you could just do nothing. And they'll say, what are the other options? The things that I could do. And then some people, if the problem was significant enough or disruptive enough, they might want to explore medication.
Yeah.
Yeah, I'm not really okay. And then so you've sort of ended up in hopefully this, well, rehab in some form is likely to be useful. But don't forget, doing nothing lots of times. And so I think the timing of how we use it, because if you come in with that, oh yeah, and you could do nothing, it doesn't really sell it.
No, no, it's almost like the afterthought, so to speak.
Yeah.
It's like yeah, it's just that, oh, there's this is over here as well, but look at these things you can do. Do you think
Yeah.
this is, you say about GPs, and I don't know what the stats are about how, if we go across the board to other just healthcare professionals in general, about how comfortable they are with doing nothing, potentially. Is there a lot of stuff out there about actually clinicians' willingness to do nothing?
I think what you read in some of the qualitative stuff in GP land, and I can certainly support this anecdotally, is that as clinicians get more experienced,
Mm,
I noticed very stark differences between people who are maybe like ST3s, so they're quite experienced doctors,
yeah.
but are relatively new into specialty training into GP land, going through all of that stuff that they have to go through, much more likely to do something.
Mm,
And this was one of the reasons that, um, although I'd come from a sort of football and coaching type background, this was one of the things that really kind of piqued my interest around consultation because the GPs would sort of, oh, come in, nice to see you, Ben, okay, okay, and very well. So yeah, how can I help? And so they'd talk and they wouldn't really say anything for about 90 seconds, and they'd sort of nod and purposefully go, and you mentioned, and so it's all the patient-driven
mm,
narrative. And then it all sort of comes, well, you've got a couple of things you could do here. Do you thought about X and Y? Well, yeah, great. Okay. And the sort of consultation concludes, great. Was there anything else that you thought that I needed to know? Okay. Nice to see you. I hope the family's okay. And and they go. And 3/4 of the time the GP turns around and goes, yeah, okay. He writes the notes. And a lot of the time they don't do anything. There's a lot of watchful waiting. But I think part of the willingness to do that is perhaps understanding of uncertainty,
yeah.
understanding of risk,
Mm,
understanding of things like timeline, and that is something that I think is really critical. So we see that probably increase a little bit as time goes by. But if you look at the data, I mean, there's an astonishing NHS digital. So this information is very much in the public domain as to the number of primary care appointments every month into the tens of millions. And of course,
yeah.
that doesn't trigger tens of millions of referrals.
No, no.
It's actually a small percentage that might get medication, but because they see so many people, oh well, 4 people out of a list of 30 got antibiotics. Well, yeah, but that means that a lot of people didn't get anything, and it's really,
Yeah,
hopefully that's all judicious and
yeah,
soundly clinical reasoned, but the relative inactivity is really high of
yeah,
watchful use of watchful waiting,
yeah.
safety netting, and all of these things.
But you made a very good point there with that, with the about antibiotics and about with the stats. Uh, and another way, especially in these conversations, we can unintentionally influence people is how we organize stats. I remember the classic, I forget, it was about 5 years ago. There's a study about shoulder surgery, and there were it was a group of patients who were waiting to see a consultant. And I can put the link to this in the uh, description. And one group got given a sentence that said, "You are going to be discussing this surgery today. In this study, researchers found that 75% of people when they have the surgery are unlikely to have a tear afterwards." And then they flipped it, and then they gave the other half this line that said, "Research has shown that people going to discuss the surgery, you're going to have 25% had a tear after their surgery." Now, anyone listening to this, and you and I can work out the maths on that. But interestingly, then found that those that had the tear, the 25%, even though the numbers lower, were less likely to pick the surgery compared to the other way around. So even though the risk was the same,
Yeah.
how it was phrased and framed, the fancy term is loss aversion, I think, um, influenced what people picked. What's your thoughts about how we can carefully use stats without influencing someone too far?
Yeah, I think that's a really good example of I don't know if you've read. There's a really good book. It's a classic by Malcolm Gladwell called Tipping Point. Have you read that?
Ah, we can
So,
link that
yeah,
as well.
it's based on sort of popular culture and organizations that changed how they behaved. So, for example, the mayor in New York City in the 80s came in with a very sort of very militant. We're going to book people. We're going to have police at the tube stations, and we're going to book people for fare dodging. We're going to clean no broken windows. We're going to take off the graffiti off the tube trains every night. We've got people painting them every night because they get graffitied every single night. And so they start to try and force a behavior change in terms of, because it was obviously one of the most dangerous places in the world at the time. Um, and gradually they chipped away at, and they caused this tipping point and influenced the behavior of the people who lived and traveled and murdered all those things.
Mm.
The good things went up and the bad things went down. So I suppose with that, how you present that, that's a really good example of trying to achieve that tipping point, isn't it? In that consultation of saying, how do I frame this in such a way? Um, I think probably the most common one that people will roll out is the Brink G, the study
Oh
of
yeah, yeah,
such high percentages of
yeah,
yeah, and I think that's a can be a really useful tool, especially if it's something that you can. I think it always adds gravitas to some of these, so I would recommend to people to get a few sheets laminated of key bits of information
yeah.
that have a slant on this that say, well, in 25% of cases, this is what happens, and you can present that in front of them so they can sort of read it and take it in,
Mm.
and it becomes part of knowledge transfer as much as shared decision making. Um, but I do think you have to be quite judicious with that. And also, kind of words are
Yeah.
quite hollow, aren't they? We can talk about the evidence base.
Mm.
And for lots of people, they're like, I just don't care. Like, t tell me what we need to do.
Yeah,
Tell me what
yeah.
we need to do.
Which is tricky because we talk about shared and want to keep shared decision making and wanting people to be involved and be discussion, but there is people who just want to be told. They don't want to get too much bogged down in the choices and the having to pick. They just some people just want you. You know, if you ask them what's your thoughts, the thought is I want you to tell me what to do about this. And I've learned, you tell me your thoughts. You can try and nudge, you can try and ping it back to them and say, well, we could say this, what do you think? But if they keep batting it back, there's only so many times before they might get more frustrated. And sometimes it might be better to kind of hint a bit more if they're really not wanting to make that decision. Or what do you think?
Yeah, it's it does happen, doesn't it? Of course,
Yeah.
I don't think there's any getting away from that. I do think that some of that is a byproduct of the consultation itself.
Mm.
It's my belief anyway that the very staccato, didactic information gathering body
Yeah.
chart of do you get this?
Mm.
Thyroid, heart, respiratory, epilepsy, diabetes, surgery, in a method of data collection that doesn't really feel like a conversation is very much therapist driven.
Mm.
The narrative of asking good questions that when the person says, oh, that's a good question, that's your time to just be quiet and listen well, and they will give you lots of the cues. And so I would say in lots of those instances, we can trim away a significant percentage of those just by changing how we frame some of our questions, because the answers that we'll get, providing you listen, you talked before about some of the cues might be subtle, some of the things that they say, but they're the things that we're sort of making a mental, not necessarily a physical note, but a mental note of think that's something that's going to come up later.
Yeah.
Because you can, one, show that you listened, which is terrific for rapport. You mentioned that before. How did you see that fitting here? Oh, well, yeah, I had a friend who did that. And what was their outcome? Well, they did really well. Okay, well, I'm really glad that you brought that up. Because in this instance, using something like that, injection, tramadol, diazepam, is there are some downsides to it. So let me talk you through those. So I think that will reduce that group to less. However, the group still remains. We would never totally get rid of the group of people who says, well, you're the expert, and I think I use my mum a lot in clinic. Seemingly, I would say, well, if you were my mum or someone that came to me at a family party, and I'm sure this has happened to you, Ben, and they come over and they go, "You're physio, right? Like, got this
Yeah.
thing.
Yeah.
Like, what would you do?" and you maybe talk to them, it's not keeping you awake at night, and you go through a very cursory sort of back of a napkin type assessment. And I say in that instance, I would say that probably the two best options are this and this, or you could combine those two. So exercise of some kind. Um, Maybe if you feel it's troublesome enough to use some medication alongside to sort of get you started. Neither of these are mandatory, but I would say those are the two best options. How do you view it? And again, you're not going to the full gambit, the full top of the pops 10-point list, because that will just erode any of the impact that you've had on that relationship build that you've spent however long on. But at least you're still harboring them in that consultation for sure. But there is a group where you maybe do have to lean and try and just say, if you were, these were the things that I would, and so you've still got a couple of options, and then invariably they will choose one, whether because of where they are in their own readiness to do something, whether they'll go for either of those. That's
Well, there's a powerful question you said, and I always have been saying more and more for the past year, and that's asking, well, how do you feel about that? Or what are your feelings or thoughts about that? Because I think when we ask someone about feelings, it gets to the crux a lot more.
yeah.
It's a lot more real in a way, if that's the best word to use, but like, then rather than just a kind of, oh, okay, here, do that. Yeah, well, I suggest this. What do you
Mhm.
think? But feelings are more internal in a way because someone you could say, "What do you think?" and they could do their exercise. They could devote their 20 minutes 3 times a week and whatever it is, and they've got the setup and all that jazz. But how they feel, maybe that they don't think it's going to make a difference,
Yeah.
or that it's they actually wanted. Hopefully, if you've got the expectation sorted, they may have wanted something else. And I, I think I found that asking people about how did you feel about that, or what are your feelings about that, just seems more powerful. It seems to get more info.
Yeah, yeah. I think probably there are a few words that fit with that. So, what are your thoughts on those, or how do those options sit with you? Again, it's quite open, and it's bringing them into that conversation, isn't it? And I think any mode of questioning that does that, it's my very firm belief that that pays off in spades. It won't remove the group of people who are unsure, of
No.
course, but I think they're probably in that place for a whole variety of other reasons as well that may be beyond the remit of that consultation on any given day. However, the advice that you're going to give them is going to be reasonable. They've got a timeline, hopefully, in which to act, and in that timeline, they've also got some very clear information about what they should do if things take a certain a path in terms of change or progression.
Absolutely. David, before we get to your hardest conversation, was there anything else about shared decision making you wanted to say that we've missed?
That's a good question. That's a good
The
question.
classic
Y-
consultation. That's the end of your subjective question, isn't it?
Yeah, I would say probably the only other thing would be um, not being too reliant on the obvious cues. And so when you get to that shared decision making, you
Mm,
obviously want to address the elephant in the room.
yeah.
And you'll say, "Oh, you mentioned that, so I really want to talk about that." Were there, and I try to avoid too much expectation, but essentially what you're trying to find out is if there was anything else that they'd hoped for,
Mm,
So we'll definitely talk about that. But there were any other things
yeah.
that you thought we might try, and so you've got those out in the open, so it's almost like a double check.
Yeah.
If somebody's already given you a couple, I think you've got to play with those as being family fortunes, and sent those out as the top answers. So we've probably got to deal with those first. So
Yeah.
that's the only other thing that I would add.
No, I often say to people with the especially your ice questions. I mean, I usually I only has one answer. Occasionally there may be more, but the especially concerns they'll say a concern, but there may be other concerns,
Hmm.
and that you can always ask about. Okay, whatever they say, and are the other concerns, or what other concerns? And you might get more, and might get to the heart of the matter. And as you say, expectations. That's quite useful actually. Yeah, what the expectations are, and whatever it is, and then okay, any other expectations or thoughts? Well, yeah, because it can that can help you that can help form that shared decision making conversation, can't it? Because that can give you more options, right?
Yeah, 100%. Yeah, 100%.
David, ask everyone this: what has been one of your hardest clinical conversations?
Yeah, so I sort of considered this really, and I think there are always times when the resolution is really difficult, impossible, or unclear. So I can think of lots of instances where, particularly in primary care, where you you think there's a certain route to follow,
Mm.
but for whatever reason the person can't do it. So you do go to option two and three, and then you really start to get into a fairly sticky area, or there's no really, we can't do an injection for this. So the options really sort of dry up.
Yeah.
So I'm thinking of one particular example, which was, and I think this represents a cluster of similar times, I think, where this was a fairly young patient, recurrent episodes of gout, and they very commonly end up in MSK clinic, and we'd be expected to manage those in almost all instances. Um, but they, not overweight, not in a particular risk category, but functioning alcoholic. So
Okay.
the most likely driver of the recurrence of gout is the alcoholism. And this is
Mm.
something that the person struggled with, relapsed into a state where they're using alcohol to manage some of the stress and so on. And in this particular instance, the the person didn't want to go to the local support service. Um, not because necessarily of the attachment or the stigma with it, but because they knew somebody who worked in that
Ah.
setting. So there was this social pressure that they didn't really. And I said, well, there's probably ways we can circumvent that. Um, we'd be able to contact them and request that they don't see you because they're a clinician. I understand.
Mm.
Yeah, I just thought, okay, so well, this is a tricky one. You're going to have to leave it with me. I'm going to do some digging. Is there another service that we can get you to that isn't this one, but is maybe a bit further away if you're willing to travel, or I'll explore other mechanisms. Yeah, yeah, sure. And of course, you do that perhaps thinking, "Oof, I'm not super confident that I'm going to be able to put you into a geographically different
Mm.
program because they offer that service to people who live in that postcode,
Yeah.
right?
Yeah.
So you sort of think, well, maybe they will in some circumstances, but they won't. And some of the other avenues that you think, maybe they are going to be good, but they're going to dry up. So you then take the time to contact them again. So they're in this sort of difficult spot where they don't really want to take the best option for a variety of reasons, but there aren't really lots of other options because managing that with medication to it creates its own problems, and that would be something that you would be cautious about. So
Mm.
it's that conversation that second time around, say, look, I've been turning over stones on your behalf, and I have hit a bit of a brick wall here, and I'm ever so sorry to say this. Had you had any more thoughts about maybe going into that service? Well, I absolutely can't. Okay. And they're engaging in some mental health support, and so they seem to be doing it all. So you say, I am a little bit stuck here, and that never feels like a great conversation to have. And I think that instance is
Mm.
sort of representative of relatively infrequent conversations that you have where unfortunately it's almost like a pain clinic type setting. So you're at the end of the road now.
Yeah. Yeah.
And if something changes, and hopefully I've built a sufficient rapport so that when something does change, they're willing to come back and say, okay, I remember that conversation. Can we
Mm.
pick that up? Or how do we take it forward with a safety net in place? So I think that instance, like I say, is representative of a cluster of those tricky ones. They're not so many,
Yeah.
but they are difficult because the ultimate reason why you and I'm sure, got into this job is to help people,
Yeah.
to get them where they want to go. And it's disappointing when you can't.
So, yeah, we didn't mention that too much. What if we said about too much choice earlier? What if there was no choice? Like, as you say, the options kind of dry up. I've had one fairly recent that still sticks in my mind that they've been through the journey with their problem, been through various imaging and procedures and whatnot, and had decent input from what we consider decent input from various specialities. And there was one option left to support, but they didn't want that.
Hmm.
And otherwise, the other option was do nothing. Um, and sometimes you just have they know once they can kind of
Yeah.
read it in your face a bit and kind of in your tone, and that you're having to think about it, and they kind of may have worked that out before, from especially if they've seen multiple people beforehand as well. If this is a long-term problem,
Hmm.
it then becomes it's hard. It was hard in a way to end it because They knew what I was saying. I knew what I was saying. It's just kind of, well, I guess we're going to have to do nothing then, not by them choosing it because of lack of other options, really. In this case, they didn't want the other option that was on the table,
Sure.
which isn't easy. I'm not saying anyone it's an easy conversation to have, but it's not. It's easy on paper because you're not having to worry about choice and bias and all that stuff. But the person loses hope at that point. It becomes a bit more of a. I often say Breaking Bad news is a lot more than life, death, and cancer, but this is another one of those examples where this is, bad news conversation. It's just it's not serious pathology. Um, but yeah,
Yeah.
yeah,
Yeah, really, really, really difficult instances those, aren't they? And I think part of me understands, having been in primary care for, almost 8 years now, that if the person gets it's not the right word to use, but the wrong clinician on the wrong day, somebody who's willing to meet an expectation to go up on the patches or whatever it is, even though the evidence screams that they're in a difficult place, is likely to be exacerbated by the treatment almost. That invariably somebody might meet that need, and I think primary care is a very um, difficult place to manage some of that stuff because they can come back on any given day. The door is always open
yeah, yeah,
to
yeah.
go in and have that conversation. Some patients do come in repeatedly,
Mm,
frequently. Others come around and sort of manage and then come back in. And some are more savvy than others about, yeah, yeah, it's not really any different. Yeah, really tricky.
it is very tricky. I like to end these by asking about the future. And we were saying in the past, and plenty of evidence, and we can all know that back in the day, shared decision making was very much you see the healthcare professional, they tell you what to do, you hopefully do it. And over time, we've become more shared, where we're involving the patients in the discussion. It's much more back and forth. You were mentioning about information available, and especially with AI and all this stuff in the future. And I don't know what the research says, you might know, but could shared decision making almost go the other way, where we've got so much access to information that they'll have their ideas and thoughts and know what before they even come through the door, and then it becomes almost the opposite of what it used to be, if that makes sense.
Yes, that would feel like a slightly terrifying sort of Skynet type world, I think, which who knows how quick we're heading towards that really with large language models and their evolution. But I think patients accessing information is generally quite a positive thing. I think, it wasn't so long ago that patients would bring in something from, the Sunday People or some, hack-like newspaper. Well, now people have the world of information at their fingertips. So not all of it is good and reliable, but often some of the stuff that they bring is has a semblance in information. Whether the future version of the health service is more privatized and actually becomes more like the American system where I go in and essentially it's not really a shared choice. It's about what I'm willing to pay for.
Mm.
And I hope not. I think there's a middle ground probably that the health service can find. I'm sure that AI, that kind of driver will have some role to play, because it can do, or it will be able to do pretty much anything.
Mm.
But I'd like to think that even that would incorporate some degree of these are the pros and cons
Yeah,
to either step, and I think
yeah.
that's a real evolution for healthcare over time.
We have to be mindful who's influencing the AI at that point.
Well, absolutely, yeah, absolutely.
So
Hmm.
David, you've got the course. Is it 1 day course? Was that right in York?
Yeah, yeah, that's right. So the essential consultation skills, kind of what's the word that I'm looking for? Roadshow sort of continues. Yeah, Saturday, 13th of September in York. There should be more dates coming up in the new year, but
Mm.
essentially that's a day on the whole consultation. I was quite lucky one day, um, when I was developing this interest. I had a chap who came and he's a bit of a GP trainer on YouTube, and he came in. And I didn't know this, and I consulted with him, and then reached out to him. He said, "Oh, I came to see you. Actually, I was the guy who rides a tandem." And I was like, "Oh, yeah." And I'd been reading a lot of his stuff, watching a lot of his stuff, and that was something that really triggered me to put the course together. From how we ask questions, how we understand ideas that concerns expectations, how we use that as part of our shared decision making, part of our summarizing, and then ultimately, the management plan and the safety netting and all that ties in. So,
Mm,
yeah, it's a busy day, but those who've come so far, it's been really well received. So I'd love to see some people there.
grand. And you said there'd be more in the future. Is that right?
Yeah, absolutely. So probably in the new year now, I think when we get into Christmas, gets a bit tricky, but maybe one in the northwest, maybe another in Yorkshire, maybe another in the south, hopefully.
Mm,
So if people want to host, they can certainly approach the MACB and then they allocate some free places and stuff.
mm.
Yeah, because it's totally portable. But face to face, there has been conversations about it being online, just the nature of the skills that are needed,
Yeah,
the
agreed.
relevance of eye contact, the relevance of
Yeah,
body positioning. These are all things that need to be in the room.
yeah, absolutely. Agree. I think from my experience, I think anything more than an hour, yeah, you should be really done in for this kind of field, should be done in person. You can give a brief overview online, that's fine. But if you need more depth than that, as people may not always like it, but the role play is the best way to learn it, and to actually go
For
and do
sure.
it. Um,
Mm.
I, I, I always feel a bit harsh with our medical school because we even I work for because you got a medical student who's I don't know late teens, early 20s. You put them up in front of this room. They've got five other students, me, and they're in front of an actor. They're being filmed, knowing that we might well play back them as well.
Sure.
Uh,
It's
uh,
tough.
yes. So if they can do that, then other professionals can go off into a group and do a bit of role play with their friend. Yeah, yeah, absolutely. I completely agree. Like a little bit online, fine, but anything more than that needs to be in person, doesn't it?
Yeah.
Anything else you want to plug?
Uh, do I? So what else am I involved in? So as the course lead at Sheffield Hallam,
Oh, yes.
we have quite a popular postgrad route, which has an upper quadrant, lower quadrant, some of the good electives around FCP, injection, imaging, the stuff taking people into enhanced and advanced practice. Can lead to MACP membership, including mentor clinical placement if people want it. So yeah, I'm on LinkedIn or the Sheffield Hallam homepage has stuff around the MSc, which is a good program.
Excellent.
So yeah, we look forward to seeing people on that as well.
Thank you.
It's a privilege.
Thank you for this, David. I will put a link to the course in the description to this so people can just click on it as they're listening now. The 30th of September, so still got time when this
Yeah,
goes out.
13th September. 5 weeks away it is. Yeah.
So still got easy time to sign up. And then I'll hopefully see you there.
Thank you. And
Thank
thanks for the
you.
invite. I've enjoyed it. It's
Oh,
been fun.
I've really enjoyed this as well. I from now on will make sure I remember my mum test for the future. Thank you, David.
Pleasure.